My name is Amos Giora, and I am the director of the Institute for Global Security, Law and Policy at Case Law School. When my friend and colleague, Jessica Berg, who is the Institute's associate director, and I began thinking about what issue the Institute could address 5 years after 9/11 and 1 year after Hurricane Katrina, we felt that the question of preparedness and threat response was highly appropriate. To that end, we consulted with Professor Nick King from Case's Department of Bioethics and Dr. Scott Frank from Case's Department of Family Medicine. I am convinced that the great issues of the day must be approached in an interdisciplinary fashion. This is very much the Institute's philosophy. This project, which bears the name Reassessing Disaster Preparedness in Hidden Response, Hidden Assumption, Unintended Consequences, truly reflects that approach. Dr. Gursky's talk today and the roundtable discussion we will be holding tomorrow with an extraordinary range of experts will serve as the basis for a major conference that we will hold here at the law school in the spring of 2008. In thinking about whose voice is a leading one in this field of enormous importance, it quickly became apparent to us that Dr. Elin Gursky fits that bill perfectly. In her capacity as the Principal Deputy for Biodefense, National Strategies Support Director of ANSER, Dr. Gursky is uniquely positioned to truly impact the public debate. Dr. Gursky is a trained epidemiologist. Thank you, Sharona. And also a public health practitioner. In addition, she has held senior government positions and academic positions. Dr. Gursky is frequently asked to testify before Congress and has been very much involved in drafting legislation. Dr. Gursky's talk, which will include questions and answers, will conclude at 5:30, after which you're all invited to a reception upstairs. We are very much honored and privileged that Dr. Gursky will be giving this year's distinguished lecture in global security, law, and policy. Please join me in warmly welcoming her to the law school.
It is a pleasure and a privilege to be here today at the Institute for Global Security, Law, and Policy, and this discussion is very much tailored to informing, to catalyzing thought, and hopefully debate and discussion. In the non-ending human struggle to overcome disease and death, we have memorialized these issues in every venue, in art, in literature, in music, in politics, and in policy. And yet the overwhelming achievements in overcoming disease and death can be attributed to public health advancements. In the 17th century, children were not expected to live much past the age of 10. The development of the microscope and subsequently decoding genetics have allowed us to make incredible advances in detecting disease, in treating disease, in preventing disease through vaccination, both in the United States and globally. In 2001 to 2005, just recently, we have reduced measles death 48% globally. At the same time, polio cases have become higher in countries like Nigeria, Somalia, Afghanistan, and Pakistan. We're getting better at disease surveillance and detecting disease in populations and crops and animals. We're using epidemiologic strategies to detect disease earlier, to understand the relationship between disease and environment and host, to screen populations at risk, to cohort populations and isolate populations who may be a threat to others, to screen people early in the disease process, to prevent disease spread. We've gone from treating people with fresh air to antibiotics and anti-infectives, to the richness of the pharmaceutical industry. We've been able to prevent disease, cure disease. We recognize that laws are an integral part of applying public health science and public health principles fairly and effectively. We've been concerned about the environment, about clean air, about the safety of our food supply, about the abundance of our food supply. The recent E. coli cases, almost 200 with 3 deaths, cost California $74 million in losses. % of the world's population does not have access to basic sanitation. Over 1 billion people drink water that is considered unsafe. Laws such as requiring seatbelt use have saved over 10,000 lives a year, and we've immeasurably improved worksite safety. The struggle to overcome behavior and lifestyle and improve wellness in populations is another never-ending struggle. 1 in 3 million Americans between the ages of 20 and 74 are considered overweight. We spend $274 billion annually on cardiovascular disease. But we have, in the 20th century, made remarkable advancements in improving the public's health through a whole host of activities, of actions, of achievements, of laws. Well, what do we mean by public health? Well, the early leaders, Charles Winslow in 1920, said that it was a science and an art of preventing disease, of prolonging life, promoting health, that it required organized community effort. It needed to focus on the sanitation of the environment, the control of communicable diseases, required that we educate people, that we had an organization for providing medical and nursing services, that we diagnose people early, and that we institute a kind of social machinery so that everyone can enjoy good health and longevity. I've shortened it. But I do think the salient parts are that it is an organized effort. It is society's premier responsibility, and the goal of public health is to promote and protect the health, the welfare, and the safety of populations. It requires all of society to achieve the goals of a healthy population. Transportation, housing, environment, laws, education, agriculture. There is not a sector of society that does not have a responsibility in one way or another to contribute to the health and welfare of populations. Big mission. And it's pretty tough. So how do you operationalize all these complex pieces and parts and goals and aspirations? What makes it so complex? Well, we've got a lot of people, and more on the way. It's really tough to make a lot of people healthy, to achieve goals of health and longevity. And we have more cultures and more languages, especially in the United States. So it's very hard to craft public health messages with different cultures and different languages that are sensitive, that are appropriate, and that are respectful. We have to deal with government. Governments can be tough. When you're practicing public health, government can be challenging, and it can be very complex. This is a diagram from 2001 as we were trying to figure out Homeland Security. and all the pieces that had to go with it, and who needed to talk with whom, and can you imagine trying to navigate this? We're still trying to imagine how to navigate this. This was an early effort by a colleague in one state, trying to figure out, well, how are we going to notify people if there's some event? And what's the wiring diagram? Who do we notify first and second? And, you know, what if we forget to notify this one? And do we have to do one before the other? And how do we account for all the pieces? Globalization has made it more difficult. People coming into this country from what used to be considered the far corners of the globe can be here in 24 hours, bringing their business, their interests, their cultures, and possibly diseases. Our food supply is becoming increasingly global. To wit, my apple juice, which I consumed before going through a TSA checkpoint. In these, what was 10 ounces, we have the fruit of the USA, Argentina, Germany, China, Brazil, and South Africa. Just here. And the threats are becoming more complex. We had the Anthrax Attacks, only killed 5 people, only affected 22 people, rocked the nation, brought hospitals, laboratories, public health departments across this country to its knees, made us think about other potential threat agents that could be used by terrorists. This is smallpox, which was eradicated. We've seen terrorist attacks not only on our shores, but that of our allies and other countries. And then we have natural threats. Although I have a colleague who says that Mother Nature is the greatest terrorist. But we've seen West Nile virus, bovine spongiform encephalopathy, mad cow disease, SARS, tsunamis. This is an early slide. How horrified we were that 22,000 people were killed. What was the final count? 250,000. And of course, our very own Katrinas and Rita. We're now concerned about H5N1 avian influenza, so far responsible for 151 deaths. And then there's just plain old spinach. Right? Mother always said, eat your greens. So we've talked about public health achievements. We've talked about the complexity of perhaps replicating those achievements going forward, but certainly dealing with a more challenging threat environment that we've seen in the 21st century. And what I'm going to do now is walk you through a number of issues that I think are germane to looking at our efforts to protect the public's health within the context of homeland security and global emerging threats. Let me start from the big picture. We built a homeland security environment that can identify and address known and projected threats. What do you think? I think probably not. I think we're working towards that. It's tough. We've studied it to some extent. We've tried to identify the pieces of this puzzle that need to be put together the federal departments that have to begin talking with each other, some for the very first time. We recognize that we really need to get everybody not only talking together, but working effectively together. In fact, we've written a lot of reports and have taken the issue of Homeland Security very seriously. A lot of very thoughtful people have spent a whole lot of time trying to puzzle this out. We have seen, we continue to see, almost on a daily basis, a number of reports that say we're probably not ready. We've had reports post-Katrina that have looked at health and public health and talked about readiness. We've had independent organizations talk about new problems, old tools, unified commands, the need to practice, the need to plan. And we had a test, and we didn't do so well. Hopefully, it was a wake-up call. So we have this evolving Homeland Security context. To what extent does public health help to drive the Homeland Security effort? To what extent is public health integrated and understood within Homeland Security? To be fair, since 2001, the role, the importance of the public's health within domestic security and Homeland Security has been recognized. Public health has had more visibility than it's had most of the time previously. And there have been a number of federal reports that have been written that have in one way or another mentioned that public health is important. The public health effort is important. Let me go on. So if the public health effort is being recognized as more important to the Homeland Security sector, umbrella, to what extent is public health being able to accommodate to those new demands? Why do I say that? Well, I don't need to. A number of reports, a large number of reports, have been looking at, evaluating, and assessing public health's ability to play a role protecting the public's health against, within a new threat context. Anthrax, SARS, influenza, and a number of issues. Let me explain to you a bit about what public health really is. We have three pieces. We have a federal component. Most of you know that as the Centers for Disease Control. We have state public health agencies, which is the statutory basis for public health activities, and we have local health departments. We call those our ground troops, where the rubber meets the road. And in attempting to walk you through this complexity, our about 3,000 local health departments and 50 state health departments are surrounded conceptually and sometimes in reality by a lot of agencies, guidance, funding streams, and expectations. Ever more so now that there is a Department of Homeland Security, that the Department of Justice is now involved in security issues and is beginning to be concerned about public health. So the complexity is increasing, and the pressures on especially local public health departments is increasing. What are these local public health departments doing? This is from a 2001 report. Immunizations, health education, communicable diseases. They're inspecting restaurants. They're doing outreach. And they're doing maternal health, family planning, prenatal care. 2006 report, doing most of the same things. They're giving you flu shots, they're immunizing children so they can go to school, they're still inspecting restaurants. They've got a huge role in tuberculosis and many other infectious diseases. They're working on issues like hypertension, blood pressure, tobacco use, behavior change. They're very busy. They have a very full plate and a very full day job. This is often the face of local public health. When you think of what is my public health department doing, it's probably an immunization clinic, maybe seasonal immunization, maybe it's catch-up for children starting school, maybe it's catch-up for children going to camps, maybe it's immunization for or PPDs, tuberculin testing for people starting jobs. This is the face of public health. What you don't see is the day-to-day work of public health departments that is invisible, that is being done to protect not people who don't have a source of health care, but everybody in the denominator. It's getting harder for public health departments to keep up. The more uninsured Americans there are, now at and passing the 45 million mark. It's getting harder for public health departments to keep up as the amount of charity care is being diminished. And Medicaid is causing fewer and fewer patients to be able to access health care through physicians and hospitals. Who is that burden going to fall on? Public health departments. So public health departments are doing what they need to do to protect the public's health by safe drinking water and healthy health protection messages. They're also doing safety net services and a lot of primary health care. Now, unfortunately, in 2001 and 2002, when we started being concerned about bioterrorism preparedness in public health departments, states were going through a really tough period financially. And there were a lot of cuts experienced by public health departments. California cut things like teen pregnancy, newborn screening. Colorado zeroed out childhood vaccinations. Florida reduced its anti-tobacco program from 39 million to 1 million. I'd say that's a pretty good reduction. So, we were giving states money for bioterrorism. At the same time, we were cutting programs essential to the social fabric of our communities and our nation. More programs that were cut: maternal child health, mental health, violence prevention, school-based clinics, elder care, home visiting, water quality, to some extent perinatal services, nursing. These are things that were being cut as we were ramping up for terrorism. And you want us to do flu also? Where are we going to get the money? Where are we going to get the time? How are we going to manage this? And another expert, current executive director of the American Public Health Association. Bioterrorism is the disease du jour. What about cardiovascular disease? What about heart disease? What about all the other diseases that kill people every day? You want us to worry about bioterrorism. In fact, bioterrorism mission has caused a great deal of tension within health departments, across health agencies, and across agencies just within communities, as people battle for shrinking bucks and attempt to do their day job. So when I say, has public health taken on this new mission? What do you want them to give up? talk about the public health workforce. Something we talked about at an earlier meeting today. Public health workforce is trained in public health practice. Lots and lots of different occupations come into public health. For those many facilities that provide clinical services, you have clinical personnel. Very few full-time physicians, many on contract, lots of other clinical care providers, PAs, NPs, nurses, nurse extenders, and people who support clinical roles. Some people who are experts in behavioral and mental health, health planners, environmental health, inspectors and sanitarians. Some people who have biostatistician backgrounds, epidemiology backgrounds. There were very few of these at local health departments until recently. Due to federal money, some of this is improving. Some local health departments have laboratory workers. So what we have is a sector that is a composite of about 50 different occupational categories. But the problem is that they're not united by a basic training or common skill set. It's not like you go into medicine and you take basic medical education and specialize, or you go into law and then specialize, or the saying that even an army cook can fire a weapon and protect himself. So we have lots of people coming into public health with many different skill sets, but not a commonality of education and less commonality of training. And many people who are getting advanced degrees in public health are pursuing careers elsewhere. It's not really lucrative to work in government, and it's really tough. So what you have are people who cannot come together in an emergency to provide surge capacity and a rapid response when the alarm goes off and there's a problem. We also don't have adequate numbers of people within the public health workforce. This is just a very small enteric pathogens outbreak, Shigella outbreak. That took a year to contain, because once you get this pathogen in a closed environment like a nursery school, it truly is the gift that goes on giving and giving and giving. This is a notional picture of a food outbreak. Different colors representing validated cases, cases that are confirmed, cases that are hospitalized, cases that eventually may be deceased. These are hugely labor-intensive and require a lot of people power. Now, there have been some efforts to try to build a workforce that is united by common education, by training, with the possible thoughts of credentialing, of licensing, of finding some way to standardize the workforce. There have been concerns about this. There have been pushback from the community regarding cost, the time that is involved in getting some type of credential, a belief that if we require commonality of training and education, that we lose the diversity in the public health sector that is so important to being in public health. I believe these are issues that can be overcome. There are a number of organizations attempting to look at some aspects of these. One is an attempt to look at credentialing or accrediting public health agencies. But for the most part, public health has been described by many people as silos. Silos of capabilities within various components of the public health mission. A silo of maternal child health, a silo of environmental health, a silo of all the things that are important to communities, but perhaps do not have the ability to come together during a disaster. Okay, integration of medicine and public health, integration of many entities in public health. But clearly within the umbrella of protecting the public's health, we must have medicine. And in order to meet the demands of a crisis in a communicable disease epidemic, these must be far better integrated than they are currently. In fact, our hospitals are in crisis. There have been many reports written about this. Hospitals have closed. They're operating on very low margins. Beds have been severely eliminated, and some of this is good. We have more outpatient surgery. We have more people with quicker recoveries. We have great antibiotics and pharmaceuticals. But were there to be big demands on hospitals, they would be overwhelmed very, very quickly. We have not been putting enough money into preparing them. There are 5,000 acute care hospitals in this country, and they're getting very, very small amounts year after year after year after year. They're getting about $100,000. And just to stock adequate medications and equipment would be twice that. We would greatly exceed our ability in a pandemic, in an unremitting infectious disease, to be able to provide beds, ventilators, and intensive care. Technology, the answer to many things. Technology, information, detection, surveillance are key to public health preparedness. Yes and no. Clearly, it is highly important, critical, that we know when there is an atypical number of cases. And clearly, the earlier we can know about this, the quicker we can remove a contaminated food, treat infected people so there are not multiple generations of disease. So this information, situational awareness, is critical to the public health effort. And we have been building systems and detection using spatial, geospatial information to help us identify abnormal numbers of cases and where they are located. And we've been building response systems, trying to train people to be ready, to be deployable, to respond when we think there's an event. But there's something that needs to happen between the detection and the response. We have to make the right decisions. We have to be able to use the information. The information that's coming in from multiple sectors, hospital, law, national security, whatever, has to be readily consumed, and it has to be understood by people who are trained, who are smart, and ready to make good decisions quickly. So we're kind of working on both ends right now. We're not paying as much attention to the middle. We've spent a lot of money on computers, a lot of money trying to build information systems. Unless we have decision support capabilities, all these systems are not going to help us much. So public health is preparing in an all-hazards context. Emerging pathogens, pandemics, natural disasters, bioterrorism, call this all hazards. So how are our all hazards preparedness contributing to national security? Why do I say this? Well, again, there have been a number of reports that have said we're not really ready for something severe and something significant even 5 years down the road. Why is that? Let's talk about how public health is organized. At the state level, we have freestanding cabinet agencies where the health secretary reports to the governor. We have super agencies where health is a piece of some organization at varying levels, division, department, what have you. And at the local level, we have municipal, we have county, we have many different kinds of public health arrangements. We have decentralized states, we have centralized states, we have mixed states, we have an absolute potpourri of how public health is organized at the local level. And for years, this was celebrated. What it meant is that public health at the local level was tailored for the community it served. This was a great thing. But it's not a great thing in terms of a globalized planet and national security. We can no longer afford to have a public health department that looks different from a public health department across the state or across the nation. We can no longer afford to have a potpourri of sizes, and capabilities, and personnel, because the threats that we will be facing will threaten us as a nation. Infectious diseases will not remain contained at a community level. Okay, so we put some money into public health. We put a lot of money into a lot of other places. Public health's gotten a good bit of money. It's gotten about 2 of these. The military is 21, so we've gotten $5 billion to improve state and local public health departments over the past 5 years. It certainly is more money than public health has ever seen before. In fact, that has proved to be extremely difficult because public health did not know how to spend the money. It was, in fact, a great opportunity that in many ways has passed us by. Because what happened when Congress said, here's $1 billion in 2002, people started to scratch their head and say, what do we do with it? Well, let's see, to be fair, we'll give it to everybody. But we don't want to be fair. Should we give as much money to a health department that's got 4 people, what are they going to do with a 5th person? Then we give to a large metropolitan health department that maybe has 50 people. Should we invest in certain health departments because of where they're geographically located, because of their capabilities, because of their size of their workforce, because we think there are more threats where they are? And so that was a discussion that played out. Should we give it more to the states or more to the locals? Well, during the Anthrax attacks, we saw the continuing debate of who's in charge and who can do the job. Is it the people at the state level? Is it the people at the local level? People at the local level were saying, if the state would just get out of our way, we could handle this. The people at the state were saying, the locals can't do this. This is too tough for them. We have to go in and save them. So money caused tremendous discussion and stress and thought regarding what should public health look like. How do you spend it? Some people said, well, gee, I spent what I got, I must be prepared. And Congress said, well, okay, you got $1 billion, I guess you want more. How much more do you want? Well, I don't know. Well, what will it take to prepare? Well, Ohio's probably going to have different needs than Florida. Going to have different needs than Massachusetts. We're going to have centralized public health in this state. Let's put more money here. So public health's inability to understand how much money it would need has frustrated Congress in saying, well, how can you spend it? Show me where you're using it. So, number of issues. Let me pull some of this together. We've seen about 30 new pathogens in the past 30 years. With globalization, with climate change, with a whole host of factors, we're going to keep seeing new and emerging pathogens. And the globe's going to look like this. This is the most recent WHO report, which is going to have lots of different communicable diseases in many countries at any point in time. Some highly virulent, pathogenic, with high morbidity rates. It's a certain. Terrorism is a certainty. For those of us who work and live in the Beltway, it's probably more of a certainty than those areas that are not as proximate to the pulse of D.C. But it is an increasingly dangerous globe. And we're going to continue to see weather changes and natural climactic disasters that are going to require us to move people, to protect people, and to initiate a response. We're due for a pandemic. The theories are mixed of whether it's H5N1, if we're going to have it this year, we're going to have it next year. But the fact is, we're due for one. We get a few every century. A moderate pandemic of H5N1 has been predicted to cause illness in 90 million Americans, that's a third of the American population, and cause about 200,000 deaths. If you haven't read John Barry's book, 1918, you should. We have to get a lot better about protecting people, about getting them out of harm's way, improving the agility of government to respond. I think we have to recognize that people who live like this day in and day out do this country no credit and certainly are going to need a lot more care during a disaster. We have to get better at matching science to our risk policy. That's going to require more situational awareness, more data, more decision making, and good policies so that people, like during the anthrax attacks, aren't deciding what their exposures were and who should get ciprofloxacin. And during the anthrax attacks, governors were making treatment decisions, union leaders were making treatment decisions, people who worked in post offices went to mass prophy clinics and said, well, I think I was exposed, I want my Cipro. So we have to come up with better policies based on risk, based on science, a lot more quickly. We have to get a lot better giving people bad news. We have to be a lot better at giving people information that is honest, that is timely, that is updated, and that allows them to protect themselves and their families. Otherwise, we will not engender the trust needed when we say, line up, we're going to give you a vaccine, we're going to give you an antibiotic, and we're going to take care of you. We have to do a little bit better than giving people checklists. These are really a good start, but I think we need to help people on a lot more practical level and give them information about what works and what may not work and what they should do and what we don't advise. The issue of authorities, pardon the pun, continue to plague us, and for as long as I've been in public health practice, it's been a problem, and it continues to be a problem, and we have to figure this out. We're still not good in logistics. This is just from last week, and I think that the last sentence is important. Having vaccine in the pipeline doesn't mean getting it to thousands of destinations in time. Having a national strategic stockpile doesn't mean that we're going to get it to people in time. As a matter of fact, there are many who believe that most public health departments are incapable of receiving the stockpile and distributing it to people at risk in a time sufficient to prevent disease. Nor have we engaged sufficiently in the discussion of if you have 30 doses of vaccine and 50 people, who are you going to give it to? If you have 1,005 ventilators in the country and 300 million people, we know some proportion will be sick and need ventilators. Who are you going to give it to? Let me skip over that. What's Homeland Security? It depends on who's looking at it, who's asking the question, who's defining it, and whose perspective we're dealing with. Okay. We have to ask a few questions. What do we want the public health sector to do in the 21st century? They're doing a lot. They're doing everything that they signed up to do to promote the health and welfare of society, to do everything Winslow said, the things that I've said in my definition, to provide primary care to people that are disenfranchised from medicine. And on top of everything that they've been doing, we want them to be bioterrorism experts, to be ready to move on a dime if there's an outbreak, if there's a pandemic, if there's an attack. It is my belief that we cannot expect the public health sector to do this all. And it is not a matter of money. It is a matter of the mission. We have to define the missions involved in protecting, promoting the public's health, and fund those appropriately. I believe that health promotion and health protection are now at a point where we require different policies, different practices and strategy, different workforce. But I believe the mission's gotten too broad to do it all well. We have to look at how we protect the country. Let me put my Kahil Gibran hat on. If you remember, your children are not your children. They are life's longing of something else. Your local health departments are no longer your local community health departments. They are now sentinels and responders to global emerging threats, natural and deliberate. And we have to build a context, an organizational framework that upholds that. I think trying to build a platform of national preparedness for global threats, organized at the state level, vastly different at the local level, is a losing proposition. And we need to rethink this. Given the missions, given the jobs we want the public health sector to do, we have to determine what the public health workforce should look like. Who are the experts we want to bring at the table to lead us, to train us, to guide us during extreme adversity? And ultimately, we have to design systems that help Americans and systems that protect America. I have proposed two models in one of my reports. One that says, let's hold public health departments harmless, let them do the traditional job that we asked them to do a couple centuries ago, but embed within them, let's call them special forces, people we give extra training to, people who are ready with a beeper on their hip to move if there's a problem. Allows the public health department to continue to function, although possibly gracefully degrading, but keeps in training and in performance a cadre, regionally organized from groups of contiguous health departments, our red teams, our SWAT teams. I've also suggested that maybe it's time to break these two apart. Maybe it's time to preserve health and health services and primary health care at 2,800, 3,000 across the country, and some much smaller number of agencies that have specialized medical, public health, legal, law, security teams that do threat awareness, surveillance, and response. Of note, the state of California in the past few weeks has taken a very bold step to separate its state health and human agencies and create a new State Department of Public Health. So I think there are ways to look at the models and think something through that will be cost-effective and efficient in the 21st century. But what I think we need to do most of all is to engage in debate that will help move us forward. And so I am going to invite you to be good questioners and good thinkers, and to help me and others who are thinking through these issues come up with some new strategies for protecting the public's health. So I thank you for your attention and invite your questions. Yes, sir. Oh.
How does our public health system compare to other Western world?
I'm sorry.
How does our public health system compare to other Western countries?
How is ours, United States public health system, compared to other countries? We're actually a lot better than many. But I think for many countries outside of the UK and Israel, which have dealt with deliberate threats a lot more than the United States, in terms of attempting to close the gap on disparities and bring access and social health programs to people, the United States really is a leader. I saw a lot of hands up. Scared you away.
You made reference to the anthrax attacks upon members of Congress. This obviously disrupts the political process. Do you know of a short-term strategy to prevent another bioterrorist attack between now and the midterm elections on November 7th, which would obviously also disrupt the political process?
Wow. You haven't given me enough time to work. You know, it's less than a week. No, I think that there was a biological attack perpetrated against a community to reduce voter turnout. Took place in 1984 in California when salad was contaminated and people were too ill to leave and go out and vote. And Oregon, thank you. I think we didn't know it was terrorism for a year till someone confessed. There are lots of people watching and being very vigilant about many issues. I think we've seen with spinach, biology is kind of a tough thing to overcome. But we're working hard on it.
One thing I've noticed since the advent of everyone worrying about terrorism, where prior to September 11th it was, well, we kind of dabble in it in the government agencies. is the duplicity within the process and the reporting structures. And in terms of threat preparedness for public health, who is better equipped to deal with that? Is it DHS or is it HHS, or is it a combination of the two that works most effectively to deal with the problem? And as currently it stands, is it being dealt with effectively?
I think there is a very pervasive recognition that we need to develop and install very good information systems. And there are some efforts taking place in a number of agencies that look at health issues, DOD, DHS, HHS. There's far more discussion across these organizations about what they should be collecting, and more discussion about the sharing of information. But some of the duplication that exists is appropriate, and I think this is an effort that Congress supports and people recognize deserves attention, and deserves funding and continued forward movement. Some of the redundancy is good. Let me also say that in terms of the information collection, the issue is not the technology. The technology exists. We can collect a whole lot of stuff about a lot of events in real time. The real issue is the permissions. The real issue is sharing information in real time. So not only does there need to be some disclosure about the type of information that each organization is collecting, but how that's going to be shared in a timely manner.
So you'd mentioned sharing information, and I was just wondering, can you discuss some of the privacy and legal concerns with sharing what may be personal health information at a higher level, more so than a community level?
What I can say is that the issue of privacy comes up frequently in my work conceptualizing health information systems. And I work with a lot of experts in informatics and in building and designing these systems. And I believe, that HIPAA was not designed to preclude the collection of information that protects the public, and that we can build systems that are de-identified, that give us information of a problem, and then at the point an identity is required, will allow us to get that information in an appropriate way. I believe that the privacy issues are real, but can be dealt with. A number of my colleagues are working on health information accounts, like savings accounts, where you hold the passbook, you hold the information security, but allow sharing, allow release of information. There are lots and lots of people dealing with this issue. I will tell you, in terms of protecting the public's health, that information, early, timely, is critical. So we've got to recognize the privacy issues and work through them in open discussion. I think this is an issue that we can work through. I don't see it as an impediment. But it's important. I'm glad you raised it. Wow. I have a question. Well, we have one up here, so.
Briefly, all this stuff has come up in the context of this individual administration. The war on terrorism, whatever you want to call it, has happened just under the Bush administration. How much has the health world prepared for the changeover in administration that's eventually going to come? And are we going to lose a lot of the progress that we've had simply because of a new political system or new government coming in to rule, or whatever you want to call it?
When are they coming? Look, I have practiced within public health under changing administrations, and there is always a recalibration. I have worked a lot this past year with the Senate. I've worked with people who are very committed on both sides of the aisle, and I will believe that people who understand this problem from both parties are going to work hard on this issue. Will there be some changes and recalibration? Absolutely. But people in public health practice and Homeland Security are going to persevere. Thank you. It's an important question.
What can be done to improve the capacity of local agencies to process vaccinations and give them to individuals?
Good question. I encourage everyone in this room to go out and meet their public health officials if you don't know them, to become part of the solution, to volunteer, to provide insight, to sit on a board, and to make your expectations of public health departments very clear. I used to hold a lot of town meetings, and there's always a risk of that. First of all, elected officials are sometimes concerned that we will share disappointing news with the public. We have more breast cancer. We have more obesity. More of our children have diabetes. You need to know these issues. If you want to be committed citizens in your community, you need to demand these answers from your public health officials. You want vaccines, whatever your expectations are. I will tell you that many within public health community, certainly Congress, are very, very concerned about improving accountability, about knowing where money is going, how it's being spent, how much disease we're preventing, what services we're providing. These are important issues, and I urge you all to get very involved in these.
Before I thank Dr. Gursky on behalf of all of us, we have a small token of appreciation for you from us. Oh, you're supposed to.
Oh, I don't. This is what a great. And it goes with what I'm wearing.
Perfect. You know, we matched it for you.
Okay.
Very cool.
Very cool.
Very cool. So everybody will be warm.
Very warm. Someone said it might snow.
There you go.
All right.
A very cool sweatshirt.
Very cool sweatshirt that I will wear with pride.
There you go.
Thank you. This is terrific.
I said at the beginning that the entire purpose of the Institute for Global Security is to truly impact the public debate. It is exactly through lectures such as this extraordinary lecture we just heard that we can best accomplish our mission. On behalf of all of us, truly, thank you very much.